Thank you, sir. Thank you for those kind words. First of all, I would like to thank you, Dr. Rohit Gupta, sir, for inviting me to Allahabad and for his endoscopy workshop. Today, we had an endoscopy workshop at sir's clinic. So, thank you, sir. And another thing I would like to tell is I was really very happy and privileged to give this CME in this Allahabad Medical Association, and I thank the president, the secretary, the scientific secretary, and everyone, all the senior doctors and dignitaries for giving me this opportunity. And I was amazed by seeing the two things here. One, I came to know that this AMA is more than 100 years old. That is older than IMA. So that is one thing, great thing. And also, I am very surprised to see the structure and the facilities, this auditorium, everything. You had here. This is one of the great thing. I think I have visited few IMAs, but I have never seen such a massive IMA structure that is we are having here. Thank you. And finally, thank you, Chairperson, for introducing me. I'm going to discuss about the management of acute pancreatitis. So I'll cover a brief overview how a patient approaches with the complaint and how to approach to the patient for appropriate evaluation and management. So to begin with, as we all know, acute pancreatitis is the most common gastrointestinal disease that requires hospitalization even today. So acute abdomen condition, this is one of the commonest cause, and the cause is unpredictable and challenging clinical course. And more important thing is we need to understand the natural course of the disease so that we can manage them appropriately at an appropriate time. And the management of acute pancreatitis has considerably evolved in the recent past that we can discuss here. So to have a practical approach and how to be approach to a patient, I just based this presentation in a clinical scenario so that that will be more connecting to the all the doctors who are listening here. So we had a case of around 35 years old male patient who presented with acute pain abdomen in the epigastric area, which is radiating to the back. So whenever such acute pain abdomen comes to us, the common things which we evaluate, one is clinical history and examination. Even till today, that is the most important thing with which we can get the diagnosis in most of the cases. And basic investigations like erect X-ray abdomen, ultrasound, and few blood investigations. So this patient had elevated amylase and lipase. X-ray was normal. Ultrasound was gallbladder was normal, but pancreatitis features are there with the bulky pancreas and there was some edema. So there is suggestion that this patient is having acute pancreatitis. Let us see the literature what it says. The diagnostic criteria is any two of the three following features if they are present that diagnose the acute pancreatitis. One is typical pain. The second one is elevated amylase and lipase. And the third one is imaging either by CT, MR or ultrasound. Most of the all the three features are present in this patient, so the diagnosis of acute pancreatitis is established here. So the next question is what is to be done next. So the first thing we need to understand here is what causes acute pancreatitis and how to approach for the management. If you look at the causes, majority of the causes are due to either alcohol or gallstones. There are certain other causes like hypercalcemia, hypertriglyceridemia, trauma, certain infections. But despite of so many investigations and evaluation, almost one third of the patients where cause is not known, these comes under idiopathic and they needs to have a closer follow-up. So in this case, as a part of the complete evaluation and to identify the etiology, the rest of the investigations were done. LFTs were normal. Urea, creatinine were elevated. Lipid profile, calcium, parathyroid, normal. There was no specific history. Next comes the imaging. The standard practice and the protocol is to do a CT scan. And one important thing I would like to emphasize here, to establish the diagnosis of acute pancreatitis, when the patient approaches first to the doctor, CT is not required. So as we have seen in the previous slide, the diagnostic criteria, it requires the symptom, elevated amylase and lipase. Even if these two are present, the diagnosis is established. So there is no need to do a CT scan on the day one if the diagnosis is very clear. The only indication where we have to do a CT scan at the initial presentation is when there is a dilemma about the diagnosis. If there is any discrepancy between the clinical history and the investigation, we can do a CT scan. Otherwise, it is not required. The ideal time to do a CT scan is between 5 to 7 days. This is very important because most of the features of acute pancreatitis or the morphological features of the acute pancreatitis will be clearly evident by that time. So we should do a CT scan around that period to have a better understanding about the morphology. The second point is whenever we order a CT scan, we should order for a specific pancreatic protocol CT. So if we see the normal CT scan with a contrast enhancements, we have a two phases, that is arterial phase and venous phase after we inject the contrast. Pancreatic protocol CT has one more phase, that is late arterial phase at around 25 to 30 seconds, where the pancreatic parenchymal enhancement is better so that we can identify necrosis very easily. So we should order a specific pancreatic protocol CT. So there are certain scoring systems are available, CT severity index, which gives a rough idea about the severity of the pancreas, which is based on certain features and also the local complications like collection, but more importantly about the pancreatic necrosis. How much is the necrosis is the factor that decides. So based on these features, the scoring system is given maximum 10 points. More the points, the more severe is the disease. So now we have understood about the case and the etiology and also about the imaging. Next is how to approach further. So the first and foremost thing, we need to understand the severity of the disease. Once we know the severity, that will give an idea about the natural course or the natural history of the disease. And finally, we should have a appropriate management plan. So coming to the types of pancreatitis, there are basically two types of pancreatitis. If you see the left-hand CT scan, the pancreas appears bulky only and there is a mild peripancreatic fat stranding and the pancreatic parenchyma is enhanced normally. So that means this is a interstitial edematous pancreatitis. So most of the cases are of this variety where almost 80% of the pancreatitis is acute interstitial pancreatitis, which has a mild clinical course here. So whereas if you see the right hand CT picture, the pancreatic parenchyma is not enhancing here. This is all necrosis and you can see some necrotic collection here. So this categorizes this as a necrotizing pancreatitis. So necrotizing pancreatitis is present in about 20% of the cases only. Only 1/5 of the total patients with acute pancreatitis, necrotizing pancreatitis is present in them. And there is necrosis and also the collections. So once we understood that the morphology of the pancreatitis, the subsequent thing is we need to understand another important thing, that is about the organ failure. Recently, with new Atlanta classification that has come in 2013, very effective way of understanding about the natural history was given, where organ failure is based on the Marshall score, where three important organ systems have been taken: the cardiovascular system, respiratory, and renal system. This is looking complex, but let me make it simple. Only we need to look for three parameters: whether there is hypotension or no, that is serious failure; whether there is hypoxia or no, that is respiratory failure; or whether there is acute kidney injury. If any one of the feature is there, that signifies that this patient has organ failure. If two features are there, that means he has this Marshall. So once we understood about the CT morphology of pancreatitis and about the organ failure, then we can categorize these patients according to the severity. There are three severity categories are there, whereas mild, there is no organ failure and no local complications that what we had seen in the necrotizing pancreatitis. So this is a mild variety. Most of these patients will recover in 2 to 5 days and we can discharge them and we can have a close follow-up. So no specific extra things are not required here. But those 20 patients where necrotizing pancreatitis is there, they can fall into either moderately severe or severe pancreatitis group. In moderately severe, they may have local complications, what we had seen collections, or they may have an organ failure, but which is usually transient. It resolves within 48 hours. But when the patient has persistent organ failure, that is either hypotension or hypoxia, persisting beyond 48 hours, then this constitutes the severe variety. So we need to be more careful here. So what I would like to emphasize here is organ failure, that is the respiratory, cardiac or renal failure is the most important deciding factor at the initial phase, and we should give appropriate importance and appropriate management. In this patient, as we had seen his evaluation, there was elevated urea and creatinine signifies that there is some organ failure, and the CT picture was on the second variety, necrotizing pancreatitis, and there is some necrotic collection. Is into moderately severe variety group. So the final or the diagnosis that we established was acute necrotizing pancreatitis, moderately severe, and etiology is idiopathic. If you look at the natural course of the pancreatitis, as we had already discussed, majority 80% are mild, and you can see the mortality is very less, 0 to 1%, and most of the patients will recover and discharge. But if you look at the necrotizing pancreatitis, and if you look at the natural course, majority of these patients develop necrosis, and subsequently this necrosis may get infected. If the necrosis, that also will give rise to some complication with some mortality. The necrosis is infected, that classifies it as an infected pancreatic necrosis, where the mortality is very high. That means the mortality is high in patients with acute necrotizing pancreatitis with severe necrosis. Let us see the management outline here. So if we look at the natural history, which we can divide into two phases. The first phase, which is based on the weeks from the onset. First one is early phase, which is first 1 week of the onset of acute pancreatitis. And the late phase is after 1 week of acute pancreatitis. So in the first phase, the clinical picture is dominated by the systemic inflammatory response with the organ failures and systemic complications. And the management involves IV fluids, adequate nutrition, and management of the organ failure. Whereas in late phase, after 1 week, local complications dominate the clinical picture, whereas infected pancreatic necrosis will be the main feature. And this requires drainage by either radiological, surgical, or endoscopic. The first and foremost are the cornerstone of management of acute pancreatitis is fluid resuscitation. As we know that acute pancreatitis patients has a lot of fluid depletion, either because of the third space losses, vomiting, poor oral intake, and multiple fractures will contribute to the already hypovolemia. In addition to that, if you look at this flow chart here, whenever there is inflamed pancreas, pancreatic enzymes and cytokines will be activated. These activate a tissue factor, which in turn activates thrombin, and there is a micro DIC type of a picture. In addition to that, enzymes and cytokines will cause vascular injury and also vasoconstriction. So because of vascular injury, micro DIC, vasoconstriction, pancreatic microcirculation will be affected. Then the parenchymal blood supply will be compromised, and that is the reason for the parenchymal necrosis. So this is all because of the fluid depletion. That signifies the importance of the fluid resuscitation in the early phase of acute pancreatitis, and that is why it remained as a cornerstone of the therapy. So once we understood the importance of fluid therapy, the next question comes, what type of fluids we should do and how much volume and at what speed we should give. So this is an important RCT where they have compared the common IV fluid solution, that is a normal saline, and a ringer lactate, which is more physiological solution. If you look at the overall differences between the outcome, the necrosis, infection, organ failure, everything is less, almost zero when they used a ringer lactate, and almost 5 to 10% when they used the NS. So this clearly says that ringer lactate is better. In addition to that, ringer lactate has advantage of inhibiting the macrophage directed inflammation in a animal experiment. So because of these features, ringer lactate was recommended as a fluid of choice in patient with acute pancreatitis. Coming to the volume, it should be a goal directed therapy where in the initial first 24 to 48 hours, we should give fluids at rate of 5 to 10 ml per kg per hour. Once the resuscitation is established, then we can have a maintenance therapy of 1 to 1.5 ml per kg per hour. But the initial phase, during the first 24 hours, the fluid volume should not be more than 3.5 liters. Otherwise, there will be complications like a fluid overload and there is a likely chances of infection. So this is the recent controversy about the volume and the rate. So the standard practice is to give around 3.5 liters of fluid, not more than that. Coming to the analgesics, the main factors for the pain here is one is inflamed pancreas. In addition to that, there will be visceral ischemia because of the fluid depletion, which also causes pain. And again, fluid importance is here again there. If the pain is mild, we can give NSAIDs. The simple NSAIDs we can give. When the pain is severe, we should consider opioid analgesic. But recently, there is a lot of discussion about the epidural anesthesia, and they compared with the opioid, non-opioid, and epidural anesthesia, where the results are better. The pain tolerance, pain scoring is better. Even the outcome is also better. Coming to the role of antibiotics, one important point I would like to highlight here is in the early phase or initial phase of acute pancreatitis, there is no role for any antibiotics. If you see the time of infection, the maximum infections are around day 14. So initially, there is no point in giving antibiotics, or we call it as a prophylactic antibiotics. When there is a strong suspicion of infection or infected pancreatic necrosis, then we can consider antibiotics. Coming to the choice of antibiotic, if you look at the pancreatic penetration of antibiotics, of all the available antibiotics, the maximum penetration is there with imipenem and meropenem. The second option is ofloxacin and ciprofloxacin. Ceftriaxone has the third grade of penetration. So the choice of antibiotics are imipenem or meropenem. Second is quinolones or metronidazole, and third generation nutrition is the most important. The rule is we should start nutrition as early as once the pain comes down and patient started tolerating oral liquids, then we should start enteral nutrition. Enteral nutrition is better than parenteral nutrition. We can give enteral nutrition in patients who are not able to tolerate oral. We can give either with tube feeding, either by nasogastric or nasojejunal tubing. And organ failure should be managed at an appropriate ICU setup. And coming back to the case profile, this patient was managed in ICU setting. IV fluids were given, oxygen was given initially, started on nasojejunal feeds. IV antibiotics were not given. He improved and he discharged on day 18. And again, he readmitted on day 15. This time he had pain, abdomen, and nausea, and conservatively tried to manage. But on day 20, he developed a fever and started IV antibiotics at that point of time. But there was no response. So again, this is a certain important thing, and we need to look at the possible factors that are contributing here. So here, as we discussed in the initial outline of the acute pancreatitis management, beyond the first week, that is late phase, the importance of local complications will come into the picture. As we had seen, interstitial pancreatitis has a very less chance of developing a fluid collection. If at all they develop, we call it as an acute peripancreatic fluid collection. And in the background of necrotizing pancreatitis, we call it as an acute necrotic collection. These fluid collections initially immature, they evolve over 4 weeks, mature wall will form, where APFC will develop into pseudocyst, whereas this acute necrotic collection will develop into walled off necrosis. This is the terminology that we are following now. Previously, there was a lot of confusion about the terminology, but now the terminology is very clear. A pseudocyst develop in the background of interstitial pancreatitis, whereas a walled off necrosis develop in the background of necrotizing pancreatitis. So I'll show the difference here. So this is the interstitial pancreatitis, and this is a collection here. You look at the collection, a mature collection, wall is formed, and the fluid contents are very clear. So this is a pseudocyst. Whereas on right side, you can see here the whole of the pancreas is replaced by this large collection, and the contents are heterogeneous here. And again, there is a well-defined wall. So this is a walled off necrosis. This requires drainage. So when to drain the pancreatic fluid collection or necrosis? We usually follow a 4-week rule because 4 week is the minimum time period that requires for the wall to mature so that we can effectively drain the collections without any complications. We should delay until 4 weeks so that we allow the wall to form. The only exception is infected pancreatic necrosis. When the infected necrosis is there, which is causing a persistent organ failure, not responding to antibiotics, then we should opt for certain modality so that we can drain the infected necrosis. These are the common indications for drainage. One is infection, which is clinically evident by fever, leukocytosis, or sometimes the patient is just unwell, sick looking without any obvious fever. So they might be having a low grade sepsis also. CT can show sometimes gas bubbles. The second indication is persistent pain. Sometimes there may be features of a large collection due to outlet obstruction like vomiting or jaundice. And important thing is size is not an indication for drainage. Whatever the size, if it is not causing any symptom, there is no need to drain that collection. So there are various options for drainage. We have a surgical option, percutaneous drainage, endoscopic drainage. Endoscopic, recently we are doing everything under EUS guidance. Dr. Rohit Gupta sir had shown a nice case where we can clearly see the puncture point. We can drain the collections very effectively. And at this juncture, I would like to highlight this important landmark paper that has came in NEGM in 2010, which almost has shifted the management strategy, which compared the open necrosectomy with a minimally invasive step-up approach. A minimally invasive step-up approach means a very minimally percutaneous drain or a retroperitoneal approach. Open is a direct open necrosectomy. You can see the primary composite endpoint was significantly high in patients with the open necrosectomy, and we can see the p-value also. So this has changed the practice where we are going for more and more minimally invasive than an open necrosectomy. And recently, few papers also coming up comparing the minimally invasive surgical approach with endoscopic approach. Again, this is a landmark paper came in Lancet from the Dutch group, where you can see the major complications or death are both similar with a minimally invasive surgical approach or endoscopic approach. Both are similar. But if you see here, both are similar and there is no much difference. But the rate of pancreatic fistulas when we place a PCD and also the length of the hospital stay were slightly higher in minimally invasive surgical group. And maybe we have to look carefully into how to select the patient appropriately. And in endoscopy management, the evolution has been so rapid that initially we used to drain these collections with the plastic stent. Nowadays, we are doing with the metal stents and the dedicated lumen opposing metal stent, that is a hot axial stent Dr. Rohit sir had shown in the case. So this is again the same thing what sir had shown. So this is a large worm. You can see the necrotic debris here. This is not a hot axios. This is a cold delivery system where we punctured, passed the guide wire, dilated the tract with the balloon, and subsequently we deployed the stent. This is a different type of a stent. This is a Nagi stent, and you can see it is draining effectively. And similarly, what we had seen earlier, they act as a port. These lumen opposing metal stent, they are very short caliber, fully covered stent, very safe. Through the stent, we can go directly into the cavity. We can see the necrosis. We can remove the large chunks of the necrosis, which is a direct endoscopic necrosectomy, which has a very effective results. We can remove all the necrotic debris. And this is the final slide. On this area, we had this important paper where we adopted step-up approach even with endoscopic drainage using a dedicated metal stent. Immediately after placing the stent, the clinical success is almost 75%, and there was no need for necrosectomy. Necrosectomy we performed only in symptomatic patients after metal stent placement, that also in a stepwise manner. Initially, we placed a nasocystic drain, we irrigated the cavity, we washed the contents. If they are not responding, still symptoms are present, then only we adopted necrosectomy, and final success rate was almost 95%. And coming back to the case, he improved, he discharged, and he came for follow-up at 1 month, and metal stent was removed. So finally, the take-home message is acute pancreatitis can be mild or severe. The initial organ failure or the necrosis that indicates a severe disease and they decide the clinical course. We need to have a risk stratification and understanding the natural history of the disease so that we can have a better management. In the early phase, resuscitation is more important, and of which the cornerstone thing is the fluid therapy. In the late phase, with infected pancreatic necrosis, drainage should be considered. Thank you.